Okay, we're going to start the podcast. This is Dr. Jamie Morano podcasting to you from the VA Medical Center. This is a talk given at the Florida Department of Health and the VA session. So welcome. Today we'll speak about the Human Immunity Deficient Virus Boot Camp number 4 called a PrEP for All Occasions. Just a little bit of a PrEP background for those rotating with us. So PrEP talk objectives, exactly what is HIV PrEP, how does HIV PrEP work, how does HIV PrEP intersect with alcohol use disorders, how does PrEP work in people who inject drugs, is HIV PrEP sustainable, and the question that you're asking your patients and yourself is to PrEP or not to PrEP your patients. So what is HIV PrEP? PrEP stands for HIV pre-exposure prophylaxis. It's a single pill regimen taken by an HIV unaffected individual prior to potential HIV exposure. This is known as brand name Truvada. It's approved by the FDA in 2012. The goal is to reduce the risk of acquiring HIV infection, but know that this has to be combined with risk reduction. Barrier contraceptives, barrier methods, mental health services, sexually transmitted infection diagnosis and treatment, needle exchange, and opioid replacement therapy. I do want to especially thank Dr. Min Ho, who has arranged some of these slides, the slides that he contributed to are at the bottom of the slide for credit. I'd also like to talk about the other little blue pill. Truvada is one pill daily. It's a combination of tenofovir disoprosyl fumarate and emtricitabine. A picture is shown here. HIV PrEP, we renew it every 90 days. We have to make sure that the patient comes in for proper clinical follow-up. The creatinine clearance must be greater than 60 milliliters per minute. And please remember, at the time of this podcast, TAF, or tenofovir alafenamide, is not approved for PrEP. So please do not use this. The reason is because TAF is engineered to be more potent at the cellular level. So that's very good when you're on ART maintenance, but not so good when you're trying to stop entry of HIV virus into the cells or the mucosa. So that's why TDF is preferred. TDF has better penetration at the entry sites. It does have greater bone and renal effects, but they're minimal with TDF. Does HIV PrEP work? Yes. A great slide from Min Ho I wanted to share with his permission. The IPREX study, sometimes you can get lost in the clinical trial name, so that's why I thought it was brilliant of Dr. Ho to give visuals. So you can see the IPREX study. It's actually a phase 3 randomized controlled double-blind placebo-controlled trial. It's done in many areas of the world. You can see South America and Southeast Asia. And it was used in MSM populations and male to female transgender. Why that's important is because this is definitely diverse populations, and it shows efficacy in different types of populations. And it showed a 92% reduction in the risk of HIV acquisition. The PROUD study was more in the UK, but also showed that there was only 1 in 13 number needed to treat. Also, there is a concept called treatment as prevention, TASP. This was an excellent study done by Cohen's group out of University of North Carolina. This is the HPTN, or HIV Prevention Trials Network, number 052. This showed a 93% lower risk of linked partner infection, early versus delayed initiation. And this was actually treatment, but this started the conversation in terms of treatment as prevention in serodiscordant couples. And why this is important is this started the conversation to say, okay, if treatment is prevention, then can PrEP also start initial infection? So PrEP is effective in heterosexual populations as well. The Partners PrEP is a very seminal study that has been used later for the undetectable as untransmittable movement. And you can read a little bit about these studies, but essentially these are very rigorous studies, and they've been showing that the higher the adherence, the more likely to prevent HIV infection. You could see up to a 90% risk reduction for HIV acquisition. You can also see that PrEP is effective in people who inject drugs. This is the Bangkok-Tenofovir study, and you can see that it was conducted at 17 drug treatment clinics, and in patients with detectable TDF levels in their blood, there was a reduction of 73.5%. So you can see the nice graph here. Also a courtesy of Dr. Ho, but very, very well done in terms of showing that it is possible to have adherence for people who inject drugs. There's also a concept called on-demand PrEP, which means that the person would take Truvada at the time of anticipated exposure event. This showed variable success, most likely because the events were very frequent. But generally speaking, on-demand PrEP is not effective. Women should really be taking PrEP consistently of 20 days. Men need to have consistent drug over 7 days to be effective to prevent infection. You can see this is another way, this is from clinicaloptions.com, this is another way of understanding some of the studies, but also you can see the more doses a week, so up to 7 doses a week, it was almost 100% effective in not acquiring HIV. And this is a nice slide, also from Clinical Care Options, that shows the effectiveness of HIV PrEP improving with adherence. You can see the Voice Fem PrEP was not very successful. They found that the tenofovir levels were not consistent in the study population, but then the PROUD study, very adherent and very effective. So a lot of questions have been asked, is PrEP successful in alcohol use disorders? We know that a lot of our at-risk youth or at-risk MSM do engage in at least binge alcohol drinking, if not heavy alcohol use. We do know generally that alcohol leads to disinhibition and higher risk behaviors and impaired judgment. And certainly our MSM populations can be at higher risk. Often other types of drugs are used in this setting. The upshot is that the literature is plus minus. There is literature to suggest that there is ability to adhere to PrEP in alcohol use disorders, and in fact it should be encouraged given the high-risk behavior. Of course, PrEP should be discussed at the time of alcohol use counseling. It should be really part of the substance use counseling package. There's some literature to suggest that those with heavy alcohol are not as adherent, but there's always a continuum, I think, of adherence in alcohol use disorders, and certainly would take it by a case-by-case basis. Also, for those who inject drugs, this population is also very high risk, certainly present late to HIV testing and diagnosis, or because usually not followed in care, and certainly have more interactions that are higher risk. Also, female partners of drug users are also high risk. Now, can this population be adherent to PrEP? The answer is yes, absolutely possible. Each patient is different, but the literature does suggest that there is adherence abilities. In fact, it should be at least offered as an option for those using drugs as part of the substance use package. Some suggest to offer PrEP in Suboxone and methadone replacement clinics, also called opioid replacement therapy, ORT. Is PrEP sustainable? Yes. Individuals with substance use disorder have been shown to be adherent to antiretroviral therapy. Not only antiretroviral therapy once infected, but also adherent to PrEP. One can consider PrEP to be a bridge over troubled water, so certainly it is a helpful tool in the toolbox, if you will, to prevent HIV. Certainly it has to be combined with other risk reduction behaviors. PrEP utilization in the United States also wanted to show that there is more and more PrEP being used since its approval in 2012. It's now increasing. It's being covered by insurance agencies. States such as the state of Florida are providing PrEP counseling services and limited supplies of the PrEP drug, and also pharmaceutical companies are offering this as well. The regimen is well tolerated. It is safe in pregnancy. Very few adverse effects. Usually the person taking PrEP is relatively young with very few comorbidities. You can see some adverse effects of abdominal pain, loose stools, or fatigue, and certainly need to watch renal function and bone marrow density, or bone density levels, I should say, with TDF. But I would recommend to continue PrEP at least until the life situation changes, or if the patient is no longer willing or able to keep up with screening regimens, or if the patient refuses to come to clinic to get those every 3-month screens. Now, HIV acquisition is possible, but it is very rare. Some examples were given. There are at least 3 examples where individuals have acquired resistant strains, so tenofovir and intracytobine resistant strains with either the M1A4V or the K65R mutation. And yes, that would enable transmission of HIV, but that is very rare. For that reason, there are actually ongoing HPTN studies to look at other PrEP regimens to take care of this situation. Also, a case of HIV acquisition has been known with very, very high viremia in the index patient. But generally speaking, PrEP is very, very effective, and PrEP is not known to cause mutations once the if HIV is acquired, because you remember there's no virus in the body when someone is taking PrEP, so there's no opportunity for resistance. That's why we screen every 3 months to make sure. To PrEP or not to PrEP, want to direct your attention to the CDC HIV PrEP guidelines. These are kind of general questions, but I think they're phrased very well and kind of keeping sensitive to the situation. This is a risk behavior assessment model for MSM, or men who have sex with men. I would ask about partners, also ask about the type of activity. This is relevant because of site testing, so we recommend triple site testing in all of our PrEP patients, mouth, urine, and rectal, due to many times infections will go undiagnosed if just the urine is tested, and that can cause long-term strictures and pain in the other sites. Also, for indications for PrEP use, right now it's indicated for adults, and we need to make sure that there's no established HIV infection. And usually we use PrEP in non-monogamous relationships. We'll get to the next presentation of U equals U, but certainly anyone interested or a discordant couple interested would certainly be candidates. Also, assessment for heterosexual men and women are similar. You want to ask about partners. You want to ask about kinds of behaviors. You want to ask about other current risk reduction activities and encourage risk reduction. You also want to see if this person is high risk with substance use, or has ongoing relationships with an HIV positive partner who may or may not be suppressed. Injection drug use, risk behavior assessment, would definitely ask questions in terms of unprescribed drugs, specifically intravenous crushed pills, because that can also put them at risk for bacterial infections, and would ask about methadone or Suboxone opioid replacement therapy, and then just asking the questions shown here. CDC PrEP guidelines, this is a nice graph. Certainly, the major categories that we think of are MSM and heterosexual men and women and injection drug users. However, as you can imagine, there are combinations of all 3, and certainly individuals who are not ready to tell you about certain kinds of behaviors. So obviously keeping an open mind as a clinician is very important, and the general themes are HIV risk, any recent bacterial sexually transmitted infection, high number of partners, and history of high risk behavior such as commercial sex work or inconsistent condom use. people are clinically eligible for PrEP, certainly you want to make sure they do not have HIV. You might need to get a viral load if you suspect acute infection. And we do want to check for hepatitis B infection and check for vaccination. I would also recommend looking for hepatitis C as well in your PrEP candidates, because now we can treat hepatitis C in as little as 8 weeks. Now, CDC HIV PrEP guidelines, we would recommend following up visits every 3 months. I think it gets confusing knowing when to check at 3 months and 6 months. I think I would just check for syphilis, gonorrhea, and chlamydia, and if appropriate, trichomonas or BV every 3 months consistently. I think that's a lot easier instead of trying to make a judgment call every 6 months. I think it's just good to be consistent with each of your patients and just do a 3-month timeline. And we do actually give out educational protocols in our clinic, so that way each patient receives standardized information, educational information about PrEP and what we're doing, so that way we keep it consistent and fair with all of our patients in terms of our policies on every 3 months testing, when we would consider urine drug testing. That way it's fair to all of your patients. I wanted to share with you the Florida Department of Health PrEP Plan of Action Toolkit. This is very, very exciting, and very, proud of the state of Florida for doing such a great job. This is a wonderful resource, and this is a good compendium of materials for healthcare providers that really brings together the wisdom of sites from San Francisco to New York, kind of in a generalized action toolkit. Essentially, the provider checklist, you can see, first of all, completing a high-risk evaluation, confirming a negative HIV test, performing a hepatitis B screening test, so that would be your hepatitis. I'd recommend a hepatitis B core antibody, surface antibody, and surface antigen. I'd also recommend hepatitis C screening. That would be an antibody, and if positive, a reflex hepatitis C viral load. You want to check a creatinine clearance and making sure it's greater than 60. And making sure that the patient is not on any other antivirals, clearly, and then inquiring about pregnancy. Probably taking a urine pregnancy test may be applicable if there's uncertainty. Also, counseling. There is an art in PrEP counseling, but it's very easy to learn, and I would encourage all physicians to consider to offer PrEP, whether they be in psychiatry or the substance use centers, certainly primary care doctors, internal medicine doctors, and always call your friendly infectious disease physician. Will be happy to assist as well and help set up your protocols. And we do have a PrEP clinic now at the Department of Health in Hillsborough at the university office, so that goes live April 2018. And all departments of health should be offering PrEP, rolling out very soon and sequentially. In any case, we've kind of gone over this, but essentially testing I would do 3 months. You certainly could do every 2 months, but you want to do at least every 3 months, no more than 3 months, using Truvada. At least for now, that's the standard of care for PrEP. And then looking for risk reductions and offering hepatitis B vaccination. I would argue hepatitis A as well, and talking about any adverse reactions. And that should probably be in your educational protocol. We do have examples that we can share with you if you're interested. We call it, kind of coined the 3-step PrEP. It's a screen, initiate, maintain. So screen for a negative HIV test, check a viral load if you think there's acute infection, if the patient's giving a history of a rash or very high-risk exposure. Check hepatitis B, C, and arguably A status. Vaccinate for A and B as appropriate. Make sure a pregnancy is negative. Check a UDS and a UA. Because remember, tenofovir can cause renal tubular dysfunctions and Fanconi syndrome. You want to make sure the creatinine clearance is greater than 60 milliliters per minute. We want to take a baseline sexually transmitted infection screen. That would be a urine NAT, nucleic acid amplification test for GC and chlamydia. Remember, we don't do urethral swabs anymore for GC chlamydia. We just take a urine. The first void is the best. and then throat and rectal swabs. The patient can do their own rectal swabs if you like at clinic, and then CBC and a CMP, and then would consider that patient education protocol contract that we talked about. Truvada, 90 days. Normally no refills. You want to make sure they come back, but certainly if they have extenuating circumstances, we do refill, but we like to see them regularly. The Department of Health recommends a follow-up phone call in about 1 or 2 weeks, which makes great sense, and then return to clinic at least no later than 3 months. You might want to consider 2 months, and then always incorporate risk reduction counseling, condom, substance use, mental health use counseling. Maintain, so you want to do a triple site STI, serum RPR. Those are the tests: CBC, CMP, HIV antibody antigen test, and ongoing risk reduction and mental health substance use counseling. So that's a prep for all occasions. Thank you for your attention. If you have any other questions, you can always write us at the email below. Super excited to roll out PrEP in Florida and in our clinic sites at the VA as well. Thank you. Bye-bye.